Hi guys, welcome back, and today we're going to talk about calcium and the parathyroid. It's a very high yield lecture too. We're going to spend a lot of time on this topic. This shows up on your step 2 surgery shelf, internal medicine shelf, and every other shelf essentially, because there's testers like you to test you on things that you already learned before and how you could connect it to a disease. All right, so let's get started. Some questions to consider. So we're going to talk about hypercalcemic crisis, talk about what are the causes of hypercalcemia in a hospital setting versus somebody who's out in the community. Somebody has a parathyroid adenoma, what kind of surgical options do you have? What are the different types of hyperparathyroidism? Dietary management of calcium kidney stones. If somebody has hypercalcemia, how are you going to evaluate them? How are you going to treat them? And what are some surgical complications of parathyroid surgery? All right, once again, it's a very high yield topic, and let's get started. So, quick anatomy of the parathyroid gland, right? Parathyroid, right next to the thyroid. There's 4 of them, 2 superiors and 2 inferiors, right? And a common question that if you might get asked, this is very rarely, but you might remember from step 1 days, is the fact that inferior parathyroids develop in the 3rd pharyngeal pouch, and they develop in association with the thymus. So, if a question asks you that where the inferior parathyroids might be, when they're migrating down with the thymus, it could be right next to the thymus down in the chest. So, and also if you're in endocrine surgery during your rotations, this will be a question that you will be asked, and you could relate back to your embryology knowledge. Some basics. I know a lot of you are confused with the nerve symptoms and some of the symptoms of hypercalcemia versus hypocalcemia. Don't get scared by this picture. This is just a similar picture that you know of action potentials, right? You need sodium to come in, potassium to go out, and you have an action potential. And nerves everywhere, right? You don't have to worry about the voltages or anything. How does calcium play into a role here? So calcium is a gatekeeper. That's how I want you to think. This might not be like the scientific explanation, but this is how I want you to think so you could remember the symptoms. It's a gatekeeper. If you have too much calcium, right, it's going to block your sodium, right? Sodium is going to go in slowly. You're going to have less action potentials. For some of the symptoms of hypercalcemia, as we're going to talk in the future, is delayed nerve reflexes. Your muscles are not working efficiently. In your GI system, you've constipated, you're not pushing everything through, so everything slows down, right? Versus if your calcium is not there, your gate's all open, right? So you're going to have more action potentials, right? You're going to increase muscle spasms, muscle twitching and sort of things like that. All right? So once again, don't have to worry about these gates and stuff. It's just kind of conceptual for you to remember the symptoms. Remember, the point of these lectures is to explain you things so you don't have to sit there and memorize a lot of things, so you can understand them. Once you understand them, it's harder to forget. So, what are some typical case presentation of hypercalcemia patients? We'll talk about some hypocalcemia later in the lecture, but hypercalcemia patients. Now, you have this mnemonic bone, stones, groan, and psychiatric overtones. I never found them useful because is just, there's way too many things. But some of the things, think somebody has constipation for a long time. Remember, too much calcium is going to block sodium. You're not going to push through everything in your GI system. Also dependent on action potential, so you're not going to peristalsis as much. Muscle spasms. Your muscle is going to not going to function as much. It's going to be just spasming. Obviously, if you have too much calcium, where does it usually come from? From your bone. So you're resorbing a lot of bone, so you're going to get osteoporotic fractures. Too much calcium is also the cause of a kidney stone. So if somebody has recurrent kidney stones, you got to think about calcium, right? And majority of patients actually are asymptomatic with hypercalcemia, and that's how a majority of them present. All right? So when you see hypercalcemia, there's, your differential diagnosis should include some of these things. Obviously, parathyroid disease, especially primary hyperparathyroidism, familial hypocalcemic hypercalcemia. Now, this is a very rare disease, about affecting 1% of patients who are hypercalcemic, but once again, it tends to show up on exams. Malignancy, so cancer, we'll talk about certain types of cancers that can release hormones that can cause hypercalcemia, but also remember, they can metastasize to the bone, right? And if they metastasize to the bone and break it down, what's going to happen to your calcium? It's going to go up. Except for one cancer that's commonly shows up on exam that does the opposite. Actually doesn't break down bone, makes bone strong, more bone, lays down more bone, and that is your prostate cancer. That's osteoblastic, not osteoclastic, so that makes more bone, doesn't break down bone. Granulomatous disease, sarcoidosis, lymphoma. Remember, granulomas have a 1-alpha hydroxylase action, right, which is the same thing in your kidney, right? What does that do? It converts your 25 vitamin D to 125 vitamin D3, right, to the active form. But now you're bypassing the kidney, right? Now you have it in your granuloma. It's just going to make active form of vitamin D. And then we'll talk about what a vitamin D. And multiple myeloma tends to show up as a secret question when it comes to hypercalcemia. We'll discuss about what you should watch out for in these people. Now, common trivia question also shows up on an exam. Can you think of a common medication that people use for a common disease that can actually cause hypercalcemia? And actually, if you're in endocrine surgery, you ask the patient if they're taking this medication because that can cause hypercalcemia. So thiazides, right? Remember, you got to review this in your internal medicine lectures, but one of the first common medication that you use for essential hypertension is thiazides, right? And some people have very sensitive receptors. So what's going to happen is you don't have to worry about all these convoluted things that you had to remember for step 1. But what happens, you block this channel, it makes it easier for calcium to come in. You get hypercalcemia with this. All right? So, and if you're forming a lot of calcium in your urine, right, you're going to get stones, right? So actually you could use thiazides on somebody who's making too much stones, calcium stones, right? So remember this connection. All right, everybody's favorite diagram. All right, let's just break it down a little bit, talk about it. And so it's not going to be too complicated. Once you understand this, everything is just going to be breeze after this. All right, so your parathyroid glands. Anything that's affecting the parathyroid gland, it's going to be a primary disease. That's how I want you to think about endocrine stuff going forward. If something affecting the adrenal gland, if the adrenal gland is a problem, that's a primary disease. If the parathyroid gland is a problem, it's a primary disease. If the thyroid is a problem, it's a primary thyroid disease, right? And what happens when a primary organ gets affected? It releases its own hormone. So in terms of parathyroid gland, it releases PTH. So in primary hyperparathyroidism, you're going to make PTH. Whereas secondary it's what the stimulus causes the primary, right? What is the stimulus for a parathyroid gland to release PTH? It's low calcium and high phosphate, right? That's how I want you to think of secondary, right? In terms of adrenal gland, particularly cortisol, right? So primary adrenal disease, primary hypercortisolism, right? What is the problem? It's primarily with adrenal, and it's going to release a lot of cortisol. Secondary is the stimulus. What's the stimulus for the adrenal gland to make cortisol? It's ACTH. And the stimulus here in terms of parathyroid is low calcium or high phosphate, right? So the secondary disease is the stimulus. So knowing that, let's go forward. So your parathyroid gland, right, makes PTH. So, and that has a couple of effects. First of all, in the bone, right, it's going to start working with your osteoblast and osteoclast. You're going to pump out calcium from your bone, which is a majority of your calcium storage, into your blood, right? So it's called bone resorption. Second, it's going to, in your proximal tubule, right, in your kidney, it's going to activate 1-alpha hydroxylase, which converts your 25 vitamin D2 to 125 vitamin D3, which is the active form. And what does that do? That causes your calcium absorption from your GI. So you eat calcium, now you have more receptors, now you're absorbing at a higher rate, right? All this leads to increased calcium. When you have increased calcium under normal glands, it's going to shut down your parathyroid glands, or not. It's supposed to be low, right? Now, this guy is a cancer, right? And he secretes something called parathyroid hormone-related peptide, PTHRP, right? Essentially, what you want to think about it is it's like PTH, but it's a different shape and structure, so it doesn't register with the parathyroid gland. So it's going to bypass it, but it's going to work the same way, right? So in the kidney, it's going to do the same thing, activate 1-alpha hydroxylase. It's going to cause the same downstream effects, right? And it's going to cause elevated calcium at the end. And your parathyroid gland is like, wow, there's a lot of calcium, so I should probably shut down, so we'll have low parathyroid. Versus here, it doesn't need feedback, it's just going to be high. So with that in mind, let's move forward. So common diagnoses. So If you have a hypercalcemia in a healthy patient who comes in, just a clinic for evaluation, most likely it's primary hyperparathyroidism. If you have a patient who's in the hospital and you discover accidental hypercalcemia, the most common cause in that case is malignancy. And why is that important? So Shelf is notorious to giving you this 2-sentence or 1-sentence question. This patient has hypercalcemia. What is the most likely cause, right? This is where it comes more. So if you know that if you're, in the community, most likely it's just primary hyperparathyroidism. If you're in a hospital, most likely cause of hypercalcemia is a malignancy. And you have the punch sign that we use that tells you it's a very high yield topic. All right. So somebody comes in with hypercalcemia, right? You want to start evaluating them. What's the first thing you do? You order a parathyroid hormone level, right? First test in hypercalcemia is a PTH level. Are we clear on that? Because that just sets the guidelines for all your treatment from now on. All right? So what if your PTH is high? If your PTH is high, you essentially got to think of two things. It's either primary hyperparathyroidism or FHH, which is familiar hypocalciuric hypercalcemia, which we'll discuss in detail a little bit later, right? But, this chart doesn't do well. If you have high calcium and a normal PTH, you still have primary hyperparathyroidism because your PTH is supposed to be low. So it's high or normal, right? So normal value does not rule the disease out. It should be very low and suppressed. So we talk two options, which is primary hyperparathyroidism, which is 99% of the case, and FHH is 1% of the time. So what are the labs going to look like? So remember the actions of PTH. What does that do? It activates your vitamin D and also works in the kidney to absorb calcium, right? But also works in the kidney to secrete phosphate. So you have very high calcium. You have a high calcium, you're going to have high phosphate, right? In primary hyperparathyroidism, remember, it's a hyperparathyroidism. So in old case of hyperparathyroidism, your parathyroid is going to be high. So high parathyroid, high calcium, and low phosphate, right? And this is something that's very common up, and it's discussed in the wards and it's shown on the exam, but some people don't really pay attention to it. Your chloride to phosphate ratio. Now, remember, PTH causes your kidney to secrete phosphate, right? So you secrete a lot of phosphate. So if your chloride to phosphate ratio is more than 33, right, then it's highly likely your primary parathyroid hormone. So if you're confused in a case and you look at the lab values and be like, let me just check this ratio out. If it's more than 33, most likely you're dealing with the primary hyperparathyroidism. Some imaging, right? Osteitis fibrosis cystica. It's a very common thing they ask you. It's essentially what it is parathyroid-related degeneration of the bone. So it's subperiosteal. So right below the periosteum is just essentially eating at the bone. It's called brown tumor, right? It just eats at the bone. You have these just brown spaces, especially in your fingers. Distal phalanges is very common, right? You can see it in fingers. You see it right here. So if you see this is a very characteristic picture that shows up. Buzzwords, it's subperiosteal cortical bone resorption. It has to be distal phalanges, it could be anywhere else, but it's usually they'll show you a picture of the hand. Now, we said majority of people with hypercalcemia are asymptomatic, right? And majority of those hypercalcemic patients have primary hyperparathyroidism, right? So it's incidentally discovered in the labs, and common case that I'll tell you is a postmenopausal woman. So think of a woman in their 50s, and this is a common question you get asked on the exam and on the wards. When should you operate? So you take the highest upper limit of your calcium levels, right? At our institution, it's 10.5, right? So if that is 11.5 or higher, so it's 1 point higher than the upper limit, right? So on the exam, they'll tell you 10.3 or 10, so look at those brackets they give you. If that is higher than that 1 point of the upper limit, then that's an indication that you should operate. If you have decreased GFR, so obviously that makes sense, right? Because of your hypercalcemia, you're injuring your kidneys, so you're having end organ damage. That's an indication that you should probably operate and address the issue. If the patient is young, especially younger than 50, so tell you a 30-year-old woman, now, just chances are if you don't operate on this, over long term, you're going to have a kidney damage. It can affect your blood pressure. It can affect all those things, right? And it could cause a lot of, remember the symptoms that we talked about, so it's not favorable. So young patients get operated. And don't forget this T-score, right? What is a T-score? It measures your bone density in your hip and your spine, right? The magic number you should remember for operation is less than negative 2.5. Anything less than that, that means more negative, right? Negative 2.6, you want to operate, right? If you have a postmenopausal patient, which is the majority of cases of primary hyperparathyroidism, right? You want to get a DEXA scan, which evaluates the T-score. And this question gets asked a lot. How do you treat according to a T-score? If somebody has numbers between -1 to -2.5, that means they have osteomalacia, not osteoporosis, osteomalacia, right? And for them, simply is you advise dietary changes, they take a lot of calcium and vitamin D supplements. If the value is more negative, so -2.6, that's less than -2.5, you start treating with bisphosphonates in addition to the supplements. All right? So remember this. Even though they might ask you a primary hyperparathyroidism question, they might give you a T-score and tell you what you should do with treatment. So, and if the surgery is not a case, they want you to treat the hypercalcemia. And once again, if you watch the adrenal incidentalomas lecture, this comes up a lot. So we're going to review this again. The MEN syndromes, right? If you have parathyroid hyperplasia, which causes primary hyperparathyroidism, you want to think of MEN1 and MEN2A, right? And then don't forget, the other disease. MEN1 is 3 Ps, right? So as you go down MENs, you lose a P. That's how you think about it. MEN1 is 3 Ps, MEN2A is 2 Ps and 1 M, and MEN2B is 1 P, 2 Ms. So you lose Ps and add Ms. That's how you think about it. You got pituitary adenoma, so the most common question you'll get is a prolactinoma, parathyroid hyperplasia, and pancreatic tumors for MEN1. So the common pancreatic tumors they want you to know is insulinoma, glucagonoma, vipoma, and Zollinger-Ellison syndrome, which is gastrinoma, right? How would an insulinoma present? So imagine your pancreas is secreting a lot of insulin. So when you're not eating, you have a lot of insulin around, so you're going to have fasting hypoglycemia. So you get sweaty, your heart racing. So somebody who's taking too much insulin. That's how you want to think about. How about glucagon, right? Glucagonoma, right? Glucagonoma, once again, go review those lectures. You have this characteristic rash around your mouth, buttocks, and your groin, right? And and you have not too crazy increased blood sugar levels. Vipoma, characteristic thing is you get a lot of diarrhea. With a lot of diarrhea, you secrete a lot of bicarb, so you get a metabolic acidosis. You secrete a lot of potassium, so you get metabolic acidosis with hypokalemia, right? And Zollinger-Ellison syndrome is you secrete a lot of gastrin, which causes your stomach to secrete a lot of acid. So the thing they'll tell you on the exam is you have multiple ulcers in your duodenum or you have ulcers in your jejunum, because under normal condition, your pancreas, by secreting bicarb, will decrease those acid levels, but you have so much acid it's even getting down to jejunum. So that's like the buzzword they want you to know. So insulinoma, you check with insulin and C-peptide, and they will be high. How about medullary thyroid carcinoma? Because if you have MEN2A and you think of medullary thyroid carcinoma, and that's characteristic with calcitonin. So the calcitonin would be high, and in medullary thyroid carcinoma, you want to evaluate the parathyroids too. And pheochromocytoma, you should go and review the adrenal lecture, because that's a very high yield topic as well. One more thing. I know calcitonin is involved in calcium homeostasis. It's opposite of parathyroid, but its effects are very negligible. What I would know is it works on the bone, and it does the opposite of parathyroid. So if parathyroid causes calcium release from the bone, calcitonin decreases calcium release from the bone, but its effects are very negligible. So how would you localize a hyperfunctioning gland? So now you see somebody has primary hyperthyroidism. You want to know if one gland is overworking, right? It's called a sestamibi scan or technetium sestamibi scan. What it does is, it gives a dye, and you can see here, right here, that you have an abnormal parathyroid gland, and that is hyperfunctioning. Or you could just use an ultrasound. If the ultrasound shows that the parathyroid gland is huge, right, then you know your answer that, it's probably that parathyroid that's working. You could evaluate it in the OR. So one thing, parathyroid adenoma, right? That means one of your parathyroids developed an adenoma, but there's one gland that is hyperfunctioning, versus hyperplasia. In hyperplasia, that means all 4 of your glands are overworking themselves. That's very important to understand. Surgical management. So if you have a single adenoma, so that's causing all the problem, you just take that affected gland out, right? Remember, MEN1 or 2A, they have parathyroid hyperplasia, and that's a genetic disease. That means all four glands have those genes, right? So all four glands are affected. So what do you do in that case? So the common theme is, if you have 4 glands affected, you take 3.5 of them out, and you take the other half of it and you implant it in the arm, right? It's because you want that other half to manage your calcium homeostasis, because if you don't have any parathyroids, right, you're going to have really bad hypocalcemia that's hard to control and increases mortality. So that's one thing to remember. So you don't take out all 4. That's not the answer. 4-gland hyperplasia, same thing as MEN1 or 2A. You take out 3.5 and then put the other half in the arm or your sternocleidomastoid muscle. All right? So let's get back to this chart. We said PTH is high. You're thinking primary hyperparathyroidism, but it could also be familiar hypocalciuric hypercalcemia, right? So how would you differentiate between two of them, right? The name tells you everything you need to know. It's familial. That means in a question they'll describe patients, that are affected. They have family members that are affected, so it'll give you some kind of family history. Hypocalciuric. So what's going to be your calcium level in your urine? Low, right? Hypercalcemia, right? So you got to be hypercalcemic, right? The reason in primary hyperparathyroidism, you have so much calcium in your blood that your kidney just secretes as much as it can. But you have a defective receptor in your calcium sensing receptors and in your kidneys and your parathyroids and FHH. So that way you're just trying to reabsorb as much as you can. So check the urine. If you have a high calcium in your urine, it's your primary hyperparathyroidism. If it's low, it's FHH. So you get essentially the same labs as primary hyperparathyroidism. It's a defect in the receptor that senses calcium. Your parathyroid gland thinks that you're low in calcium, right? Your threshold is higher. Essentially, that's how you want to think about it. And to differentiate between them is you check urine calcium levels. One thing, this is usually a benign disease, even though they have high calcium levels, right? So that's why you don't do parathyroid surgery on these people. Okay, so do not do a surgery. All right, so now we check their calcium levels. It's high. Then what do we do first? We check the parathyroid hormone. And we check the parathyroid hormone. This is low. This is worrisome, right? If it's low, that means your parathyroid is actually responding to your high calcium levels, right? It's actually responding. So the problem is your parathyroid gland, right? So what can this be? Somebody can take a lot of vitamin D, which is highly rarely they'll ask you in a question. It could be cancer, which is a very high yield topic, right? Don't worry about milk alkali syndrome, even though it gets mentioned a lot. It's highly unlikely you get tested on it. And hyperthyroidism, it doesn't get tested a lot. So one thing that you want to think of is cancer, and we'll discuss some other things that it could be, right? So what do? If your PTH is low, you get the PTHRP, right? Remember, PTHRP does not respond to calcium or anything. Your PTH does. In this case, your patient is hypercalcemic. Your PTH, your parathyroid gland, is responding by not secreting PTH. It's like, well, there's a lot of calcium. Why do I have to secrete, right? So that's why you check to see if there's something else that's activating and all those downstream effects of parathyroid gland, right? So you order that. If that is high, then one thing that can secrete that much parathyroid hormone related peptide, and that's going to be a cancer, right? And what kind of cancer? The majority of questions that you're going to get is going to, center around squamous cell carcinoma of the lung, right? So the typical case that will ask you about is a 70-year-old male who has a 50-pack year smoking history who comes in 2 weeks of, hemoptysis. Now, remember, squamous cell carcinoma of the lung is central, right? So it's central in the chest, and it's going to have hemoptysis because, centrally you have a lot of vessels, the bronchial vessels, so it's more likely to get hemoptysis, right? And this patient comes in, you do routine labs, and this patient is having, calcium level 11.5. That should already trigger something that this patient is suffering from squamous cell carcinoma of the lung. As we talked about, it has the same action as PTH, right? So what is it going to cause? It's going to cause high calcium, right? Because it's activating all those downstream effects. It's going to cause your kidneys to secrete the phosphate, so you're going to have low phosphate, right? And then your high calcium is going to suppress the PTH, and that's why down in this algorithm your PTH was low, right? So you got to think of squamous cell carcinoma of the lung. Back to this algorithm just to remind yourself how it's all happening. Affecting the kidney, activating vitamin D, you reabsorb it, your kidney starts reabsorbing the calcium, you excrete your phosphate, so that means your cell calcium is going up and it suppresses down your parathyroid glands. All right, what if your PTH-RP is low? Does that rule out cancer? Well, not necessarily, right? So you want to find out if that is because of vitamin D related disease, right? Because if you take a lot of vitamin D, obviously you're going to have high calcium, right? But what can it be? So it's very highly unlikely they're going to tell you somebody who's taking too much vitamin D. You might see this on a psychiatry shelf if somebody's over-medicating themselves, but you're not going to see this on a surgery shelf. If your vitamin D is high, you want to think of some kind of granulomatous disease or a lymphoma. And the common granulomatous disease they ask you is sarcoidosis. So think of a African-American patient with hilar lymphadenopathy, right? Going to have some kind of eye issues, with vision issues. They're going to have hemoptysis or affected their lungs, right? And they'll have hypercalcemia. If it is low, then you still got to think of cancer, but the mechanism here is different. It's not the same as parathyroid hormone-related peptide. Common thing, the second most cancer they're going to ask you about that causes hypercalcemia is breast cancer, right? Breast cancer can release PTH-RP, but it's not as much as a squamous cell. It can metastasize to your bone. If metastasis to your bone destroys your bone, right, what's going to happen to your calcium levels in your bloodstream? It's going to go high. Same thing with multiple myeloma. With multiple myeloma, the common thing they'll tell you, the ESR, erythrocyte sedimentation rate, which kind of measures the inflammation in your body, is going to be high. You're going to have anemia because remember, with a lot of inflammation, your body kind of stores ferritin. You get anemia with that, and you get worsening kidney function. Remember, you have a lot of monoclonal antibodies that are secreted, and they're too big in your kidneys. They cause kidney damage, right? So think of these things when they're discussing, and they'll tell you about hypercalcemia in these patients. So think of multiple myeloma. So they'll tell you about 60 or 70-year-old male who's comes in, and you have these labs. Common imaging finding that you see multiple myeloma. So they'll show you skull imaging, and then you see these dark areas that are circular, like kind of looks like holes just all over the skull. You want to think of multiple myeloma. Now let's talk about secondary hyperparathyroidism. When you see secondary hyperparathyroidism, you got to think of it renal failure versus vitamin D deficiency, and that's all they'll ask you. All right, so back to this chart again, right? So let's talk about renal failure first. So we take out the kidney, right? So what does that do? So if your kidney you have end-stage renal disease or kidney failure, right? You're on dialysis, so your kidney's not working. That means your 1-alpha hydroxylase is not working. So you're not activating your vitamin D. If you're not activating your vitamin D, you're not absorbing calcium from your gut, which is majority of the calcium absorption, right? If your kidney is gone, you're not reabsorbing calcium from your by your kidney. So your calcium reabsorption is gone. But you're also not excreting phosphate. So what's going to happen to your phosphate levels? Your phosphate levels is going to be high, right? So that's another stimulus to your parathyroid gland. So all what it does is you block your calcium homeostasis. So you're not secreting a lot of calcium into your bloodstream, right? The only way you're doing it is from your bone, right? But remember, you're not excreting phosphate. Phosphate is a negative compound, right? What is that going to do? It's going to bound something positive. What's a nice, convenient positive that it's going to bind? It's obviously calcium from your bone, right? So your body constantly is under hypocalcemic conditions, right? And your PTH stays high. So essentially, you block your calcium down here. What does that happen? Your body's like, wow, there's a lot of phosphate because you're not excreting it. There's low calcium because you're not absorbing it or you're not reabsorbing it in the kidney. Your parathyroid gland is going to be like, oh, I'm just going to secrete PTH. So this is how secondary works. All right, so let's talk about vitamin D, right? So kind of quick review. you convert your sunlight, you convert your cholesterol through the cholesterol enzymes. Kind of have to know from step 1 to vitamin D3, which is inactive, right? It goes to your liver, you make 25 hydroxyvitamin D3, and then you go to 1 alpha hydroxylase to make it to 125 vitamin D3, right? The active form, right? And that's the one that causes all those downstream effects. So what is that going to do? So essentially, we're taking out vitamin D here, so you decrease your calcium reabsorption, right? And then that causes your decreased calcium, right? You're not absorbing as much calcium. So big stimulus for your parathyroid glands is low calcium, right? If you have low calcium, now what is going to happen to your phosphate? Your kidney is working fine, right? So you're going to secrete a lot of PTH, which is going to cause, you secrete the phosphate because your kidney is working fine. And then your vitamin D is the one that's like the major contributor here, because that's where majority of your calcium comes in, right? So that's where the common the difference between the two comes in. So this is a very high yield fact. So both of them are going to cause secondary hyperparathyroidism, right? But which one is what? Your renal failure, right? Remember, your kidney is not working. Your kidney is the only way I would think about how it's excrete phosphate. My bad. So you'll have low calcium because you're not reabsorbing it, right? And you also have a high phosphate because you're not, peeing it out, right? So you have high phosphate, and also is going to bind the calcium. So that's your renal failure. In vitamin D deficiency, you have low calcium because you're not reabsorbing it, right? But you have a lot of PTH, and your kidney is working fine, and it's going to cause you to excrete the phosphate. So you have low calcium and low phosphate. So what's the treatment? If you have a renal disease patient, they rarely get a parathyroid surgery, right? You give them calcium supplementation, you give them, vitamin D, active vitamin D, right? Because you have to give them 23 vitamin D because the kidney's not working, so you can't give him, you have to give him 125 vitamin D, not just 25 vitamin D. So you have to give him the active form. And you got to excrete phosphate. Remember, phosphate binds calcium, so essentially you have low calcium, it's going to secrete your parathyroid hormone. So when do you do surgery? You do surgery if you have serious complications. So what is that? Calciphylaxis, your tissue starts calcifying. You have pruritus. So one of the common things of hypercalcemia and renal disease is you have too much calcium, you get a lot of itching, right? That's going to be very, discerning for the patient. So that's when you would do operation. But this is very rarely gets done, and so highly unlikely to get asked in the question. How about vitamin D deficiency? Or in kids, it's called rickets, and osteomalacia, somebody who's older, right? So what do? They have vitamin D deficient, you give them vitamin D, right? Their calcium is low because you're not reabsorbing, so you give them calcium. Remember, their phosphate is low, right? Because they're peeing it all out, so you give them phosphate. So you give them all three. What if you can't do surgery? It's not a very high yield topic for surgery, but it might show up on your internal medicine shelf, so we might as well just cover it here. Cinacalcet, which is a calcium mimetic, it mimics calcium, right? So your parathyroid thinks there's calcium around, so what is it going to do? It's going to stop secreting PTH. There's no mortality benefit, only symptomatic relief. And this is just a little chart that shows that your calcium your PTH levels decrease after administering cinacalcet. So this is a very high yield question. So you do the parathyroid surgery. There's going to be a couple of complications they're going to ask you about. The first one is going to be neck hematoma. How are they going to present it? They're going to be like a patient is in a recovery room and now they're having difficulty breathing and they're having a stridor, right? There's a hematoma, there's blood buildup in the neck compartment, right? It's causing difficulty breathing. So what do? You're in a recovery room, you open that incision. You don't go to the back to OR first. You open that incision, then take the patient to OR. And this is the same idea. This can happen in thyroid surgery. Remember, parathyroid is right next to the thyroid, so this is going to be the same complication, right? So thyroid surgery or parathyroid surgery, neck hematoma is a big thing. Another thing they'll tell you in the case is, the patient is hard to ventilate, right? Because remember, the hematoma is pressing on your airway. It's going to be hard to ventilate. Another thing that you get asked about is postoperative hypercalcemia, right? Bone hunger, right? Remember, somebody who's constantly secreting a lot of PTH, right? You're making the bone to resorb and excrete all the calcium, right? So it gets hungry. So what it does is, as soon as the PTH goes away from the surgery, right, it starts, absorbing all the calcium, right? And so what symptoms you're going to have. You're going to get perioral numbness, that's what they'll tell you, tingling in the fingers, symptoms of low calcium, right? So hyperactive muscles, or muscle spasms, twitching. Remember the Chivostak's and the Trousseau sign where your muscles are twitching, right? Think back to what we talked about sodium. There's not a lot of calcium. There's not a lot of gatekeeping, right? So your body's just going to, overwork itself. It's going to be hyperactive. So numbness, tingling, muscles twitching, that's what you want to think about. So you give out calcium and vitamin D, and you got to monitor them. Or you could also cause parathyroid injury, right? So it's caused dangerous hypercalcemia. Same idea, calcium and vitamin D supplementation. And this can also happen after thyroid surgery, and it's a very high yield thing to understand is that is the most common complication of a thyroid surgery. So you will most likely see this parathyroid injury, perioral numbness and tingling, and hypocalcemia after thyroid surgery kills. And we'll discuss in our next lecture about thyroids. All right, tertiary. When you think of tertiary hyperparathyroidism, you want to think of renal transplant patients. So what happens in renal transplant patients, right? So remember, renal failure patients are secondary hyperparathyroidism. So it's constantly, there's low calcium, there's high phosphate, your parathyroid is just secreting PTH, right? It gets to a point after long-standing time, right? Your parathyroid gland just loses its feedback. So it's just going to constantly becomes autonomous because it's like, wow, I got to secrete a lot of PTH. So it just keeps secreting PTH. Even after you do a transplant and you fix the electrode abnormality, it's still just going to secrete a lot of PTH. Now, if you look at these lab values, right, it's the same thing as primary hyperparathyroidism, right? You have high calcium, low phosphate, and then high PTH. Your kidney is working here, right? So it's going to secrete the low phosphate. So that's why you differentiate between secondary and tertiary. And it'll tell you that this patient was on dialysis like a year ago or had some kind of renal transplant to kind of give you a hint about tertiary hyperparathyroidism. Treatment here, you take out 3.5, and the other one that you transplant into the muscle in the forearm. Why do you put it in the forearm? Is because if it hyperfunctions again and you want to control the calcium, right, it's easier to go into the forearm to do the surgery rather than go back into the neck and do it again. Now, before we leave in parathyroid hormone to discuss some things, anything that causes elevated PTH is going to cause elevated alkaline phosphatase. So remember back from step 1, PTH activates osteoblasts, which releases osteoclast activating factor, and then that causes osteoclast to work, right? And then the enzyme way to represent that is alkaline phosphatase, right? It doesn't tell you anything specific, right? A lot of diseases that can cause bone damage is going to tell you that. So watch for this lab value in the context of the question, but it's not going to tell you if it's primary, secondary, or tertiary hyperparathyroidism. But low ALP will tell you something. And the only thing on the exam that I could think of that's very low ALP is going to tell you about is Wilson's disease. That's the Kaiser-Fleischer rings and somebody who's having liver failure and copper metabolism. We'll talk about it in liver lectures. All right. So now let's talk about specific calcium cases. Before we do that, let's talk about the calcium in the blood. Essentially, there's two ways to think about it. 40%, let's make the number easier, 50% is bound to the protein, and that protein is albumin. And then there's other 50% that's ionized, right? Just the calcium that's an ion in your blood. That's the active form. That's what PTH feels. So 50% is bound to calcium. Think of it as storage. And 50% is ionized. It's the active form that does all the things. So now, what can change? So remember, calcium shares its receptors or spaces in the albumin with hydrogen, right? Which is, think of it in terms of acidosis or alkalosis, right? So in alkalemia, what happens is there's not a lot of hydrogen in the blood, right? So the hydrogen that's on the albumin are going to go away. There's going to be empty spaces where the calcium is going to come in and sit. Right? So where does that other calcium come from? That comes from your ionized version, right? That's the one that's floating in your blood. It's going to come there. So your ionized calcium is going to be low, right? So you're going to get symptoms of hypocalcemia. And where would you have alkalemia that's very rapid and just going to have these symptoms? Hyperventilation, right? Think of a patient who's breathing really fast. you're going to take a lot of the acid out, right? You get respiratory alkalosis. Ionized calcium is going to come in on albumin. You essentially get very hypocalcemic symptoms. So what are the common symptoms that people in panic attack do, right? Panic attack people hyperventilate a lot, and they say, oh, my mouth is tingling, or my skin is tingling, my fingers are tingling. And that's because of the calcium levels. Liver failure patients, right? Liver failure patients, they cannot synthesize albumin, right? If you have low albumin, that means you have low protein-bond calcium, right? Remember the storage that we saw on the chart, right? So right here, so that is gone. So then, but your ionized calcium level is normal, right? That's the active form. That's what the PTH is. So essentially, you don't have those symptoms. But remember, when you measure calcium levels in a lab, it's the protein bond that you measure, right? So you measure calcium, it's low, but your PTH is normal, right? You're like, So you want to measure the ionized calcium to confirm that it's because of the albumin effect. But also, if they give you albumin levels on your lab, you want to correct it, right? And the correction is this formula right here, but let's simplify this. Remember this number 0.8. And your normal value is albumin in the blood is, let's average it out to a nice number of 4. So for every 1 below 4, right, you want to add 0.8. So if your albumin is 3, right, that's 1 below your normal value of 4, and let's say your calcium is 8, right, you want to add 0.8 to that. So if your albumin is 3, your calcium, you're going to add 0.8, it's going to be 8.8. So that's how we think about it. If your albumin is 2, you add another 0.8 to 8.8, so you have 9.6. So essentially you have normal calcium, right, but you could have low albumin. So for every 1 you go below 4 for your albumin, just add 0.8 to your calcium number. Calcium kidney stones. It's a very high yield topic too. You get asked about it, pretty much every shelf that you'll have. So majority of kidney stones are calcium related, right? But they'll ask you, what kind of dietary advice do you have? You don't want to restrict calcium, right? Don't restrict calcium in these patients because it's actually shown that it's going to increase your kidney stone formation. So don't do that. So advice you want to give decrease your meat consumption, increase your citrate consumption, right? Remember, citrate bounces the calcium in your urine, right? So it's less likely you're going to have calcium, forming together, complex and making a stone. And drink lots of water, right? You drink lots of water, you make your urine dilute, you don't concentrate it, so you pee it out rather than make it into a stone. How about hypercalcemia after blood transfusion? So remember, blood products are preserved as citrate. We just talked about what citrate does. It complexes with calcium, takes it away, right? It's a very negative ion, and calcium is a positive ion, right? So essentially, they're going to complex together, and you're going to have low calcium in somebody who got a blood transfusion. Tumor lysis syndrome. What's tumor lysis syndrome is your tumor cells are lysing, right? So you want to think of these with a lot of tumor cells. So hematologic diseases, or lymphomas, and leukemias, where there's a lot of white blood cells, and you give them treatment, so your lots of cells, you're going to die. What are they going to secrete? They're going to secrete phosphate. Right? What does phosphate do? So remember in our secondary hyperparathyroidism lecture, phosphate complexes with calcium, right? You get hypocalcemia symptoms, which is tingling, muscle spasms, and Chvostek's and Trousseau signs. And what are other labs that you're going to see? So your dying cells are going to secrete a lot of potassium. That's dangerous. We'll talk about it. If you refer to our fluids and electrolytes lecture, you'll see why. And hyperphosphatemia, we talked about it, right? That's going to complex with the calcium. And before we wrap up this lecture, let's talk about this case. You have a 47-year-old alcoholic homeless man who comes to the ED after he was found unconscious by the emergency medical personnel. He's resuscitated, intubated due to concerns for aspiration. He's difficult to extubate. So on day 3, you want to start giving some kind of nutritional support. So you would do it with TPN, total parenteral nutrition support. Essentially, you're feeding him through the IV. The intern in the morning, who's caring for this patient, gets a routine EKG, and it shows this EKG. Now, in this EKG, a lot of you might think, oh, this is a peak T wave, but the T waves are not bigger than your QRSs, so it's not that. But if you look at where your T wave ends and where your QRS begins, right, it's a very large interval. So you have a very large QT interval, and that's dangerous. What can large QT interval can cause? Yes, torsades de pointes, right? It's because of ribboning, and we'll talk about it in our cardiovascular lectures, and you could refer to your internal medicine lectures for more information. So, long QT after TPN in a malnourished person. How you know it's a malnourished person? So think of a cancer patient who's not feeding well. Think of a homeless man. Think of an alcoholic who's just drinking and not eating. This is called the refeeding syndrome. It's a very high yield topic for surgery. What happens is your blood levels of electrolytes are fine, in a malnourished person. But as soon as they eat, right, that causes, your potassium, calcium, and magnesium, right, to go into your cells. So in your plasma, you have low potassium, calcium, and magnesium, and even phosphate. And anything low is going to cause a long QT, right? So that's how you want to think about it. It's the insulin that shifts them intracellularly. You have low calcium in the plasma. And go back to the electrolyte lecture again to review this, right? Causes respiratory and cardiac defects, right? A long QT leads to torsades. And just kind of out of curiosity, how do you treat torsades? Well, if you said magnesium, then you'll be correct. Now, you have this case, patient, so I apologize. So this should be a hypocalcemic patient, right? If you're not hypercalcemic. So if you have a hypocalcemic patient who's not responding to supplementation, right? You give them calcium and vitamin D and they're not responding. What do you have to do? You check magnesium, right? Magnesium essentially is a cofactor for your PTH, right? So if you have very, very low magnesium, your PTH is not going to, PTH sensing receptor is not going to work a lot, so you're not going to secrete a lot of PTH. You're going to be very hypocalcemic. So you want to think of that. Common question that you get asked, no matter what shelf you're taking, essentially in step 2, is hypercalcemic crisis, right? Think of a patient who has a severe, elevated calcium level, so more than 13.5. So what do we talk about? If too much calcium, it's blocking your sodium to enter, right? So in your brain, you're thinking, oh, well, your brain's not going to be active at all. So what is that called? Coma. Same thing in your cardiovascular. You can get cardiovascular collapse. So you want to treat this really, really, really fast. So what do? The first thing you do, you give a bolus of normal saline, right? What is that going to cause? You got to pee out the calcium. Your kidneys is just going to dilute it, and when you obviously make urine, you put a lot of electrolytes in it, right? So you got to pee out calcium. And then once it starts working, you could give the patient furosemide, loop diuretics. Remember, loop diuretics will make you, it's not calcium sparing, unlike the thiazides. So the loop diuretics will cause you to pee it out. All right, so that concludes our lecture. Hopefully you could go to, what the questions we're considering here and you could answer them. We just discussed how to manage hypercalcemic crisis. And then what's the common cause of hypercalcemic in hospital setting? It's a malignancy. Surgical management, if you take out the adenoma versus 3.5, we go over, review that as well. Different types of hyperparathyroidism, calcium kidney stones. Remember, do not restrict calcium in those patients. Our treatment algorithm for hypercalcemic patients, and some of the complications such as neck hematoma and hypocalcemia. So this concludes our lecture. It's a very high yield lecture. I'm very sorry that it's taken as long of a time, but hopefully it'll be very useful. And see you later.